Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Janine Cook-Garard from the nursing department here at Nassau Community College, along with Nassau Community College student Gina Peter. And today we're going to learn all about prostate cancer and how it may affect people of certain races differently.
While prostate cancer is one of the most commonly diagnosed cancers in men in the U.S., research shows that it's more common among Black men compared to other racial groups. Our guests today are surgeon and urologist Dr. Arnold Bullock and radiation oncologist Dr. Lannis Hall, who are here to share important information on what all men should know about prostate cancer.
Doctors Bullock and Hall, welcome to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. Welcome.
Thank you for having us.
First of all, I hope you both are doing okay in light of this COVID pandemic. Has the virus affected either one of you personally? We'll start with you, Dr. Bullock.
Yes, it has. One of my children, who is an active gym buff, was going to the gym on a regular basis and ended up, fortunately, with fairly asymptomatic COVID and is doing perfectly fine at this point, but it was a bit of a scare for a moment.
And Dr. Hall?
Yes, I actually have my aunt who was in the intensive care unit for over 30 days with COVID, and I am so thankful that she was able to transfer out of the intensive care unit, go to rehab, and is now back home doing well on no oxygen.
Excellent.
And my other aunt also developed COVID too and was in the hospital for a week, and she's doing fine too. So thank you for asking.
Yeah.
Sure.
So tell us briefly about yourselves and your career path that brought you to being experts on the subject of prostate cancer. Let's start with Dr. Hall this time.
I went into the field of oncology because I lost three of my relatives, my grandparents, two grandfathers and a grandmother, to preventable cancers. I went into this area where I specialize in prostate cancer, which is a little bit unusual because the disease is fascinating in that there's a wide biologic variability. For many men, it is an indolent, very slow-growing disease, but for other men, it can be quite lethal. But at the same time, the cure rates are exceptional. Over 99% are found early. So a advocacy message is so important for our men in our community, and I gravitated towards that message in the treatment.
And Dr. Bullock?
Well, I decided to go into medicine after being involved in the American Heart Association as a 10th grader and won a summer fellowship award to work with a cardiac surgeon, African-American cardiac surgeon, after my 10th grade in high school. And that experience was so amazing, just seeing how hospitals work in the operating room. And at that point, I committed to doing better. I was already doing pretty good in school, but doing even better, and able to get into medical school and do that. I always thought I wanted to be a cardiac surgeon, but while I was at the Johns Hopkins School of Medicine, I worked with Dr. Patrick Walsh, who was one of the biggest names, or the biggest name in prostate cancer in the early 80s, and worked in his lab. Came to WashU to continue my work in prostate cancer and bladder cancer by working under Dr. Catalona. And Catalona was fairly responsible played a big role in PSA being approved by the FDA. And so that's my experience. That's how I became a specialist in prostate cancer.
So now let's start from the very beginning, especially for those that don't know. What is the prostate? Where is it located? What does it do?
So the prostate is a accessory sexual organ, sex gland in men. The prostate sits just below the urinary bladder. There's a tube in the middle of the prostate called the prostatic urethra. So your urine goes from your bladder out through the prostate and then out through your penile urethra. So when men have trouble urinating, oftentimes it's because the prostate impinges on that urinary tube. But the prostate is only there to aid in fertility. Most of your ejaculate comes from your prostate and seminal vesicles, not from your testicles. So it's a myth that people with prostate cancer would have troubles urinating, because most people who have prostate cancer, it's unrelated to symptoms. So that's the most important thing to know, that you can have troubles urinating due to your prostate, but most times it's due to benign prostate disease. Troubles urinating, prostate cancer typically should be considered asymptomatic in the early curable stages.
So the gland is not very large at all, but absolutely essential for reproductive activity. The secretion from the prostate gland at the time of sexual intercourse is alkaline, and it helps to neutralize the very acidic environment in the vaginal canal, so it allows the sperm to survive. So none of us would be here without the function of the prostate gland. So in that way, it's amazing. The flip side is, after we don't need it anymore, when we get to a median age of around 69, where prostate cancer is most commonly diagnosed, most men are not trying to have children. So it then becomes an organ that we need to monitor to make sure that there isn't a malignant transformation in the gland.
So how prevalent is prostate cancer in men, and how much more prevalent is it in black men?
Well, prostate cancer is certainly more common in black men than in white men by 70%. And the exact reason why African American men are at greater risk is not entirely clear. But just because we have a higher rate of developing prostate cancer does not mean that we couldn't benefit the same from preventive screening with PSA testing in order to pick up cancers at an earlier stage and have a far greater chance of being cured of the disease.
Very interesting, and very. I see that it's a very different percentage among African American men versus Caucasian men. How about other ethnicities like Asian or Hispanic? How does prostate cancer measure in those other cultures?
So interestingly, Asian men have the lowest incidence of prostate cancer and the lowest mortality, and Latino men actually have a lower incidence than white men or African American men. African American men have the highest incidence in the world, comparatively to, I would say, Caribbean men, and the mortality rate is double than what we see in white American men. And one of the messages we want to make strongly today is that when you're in an equal access healthcare system or participating in a clinical trial where there's standardization of care, and where care is designed and given evenly, regardless of race, we see no difference in outcome. So the disparities that we see in the mortality rate for prostate cancer and the death rate from prostate cancer are due to more social economic factors, access to care, quality care, where you're getting your care from, delays in care, but not because the treatments are not effective. The treatments are equally effective across the population. And that's an important message. It gives us hope that this disparity can be remedied if we give guideline-directed quality care.
So we're looking at more care disparities rather than disparities as it relates, or differences as it relates to diet or exercise.
Or the biology of the disease, yes. So the treatments are effective. So when you see the randomized controlled trials, for example, for radiation, and they show that there's not even a % difference in outcome, and in fact, in some studies, African American men have done better than white men, And then we have VA studies where it's an equal access center to primary care doctors and treatment and technology. We see no differences in outcome. But then we go to population data across the 50 states, and it shows this double mortality in African American men. And then further studies shows delays in treatment, delays in diagnosis. The quality of treatment is also inferior. We recognize that the disparities that we see across our society and every other aspect of life, it would be naive to think that it would not also be the case that there are these disparities in the way that we care for men based on race and ethnicity.
When should men get tested for prostate cancer? Is there a specific age range or other criteria?
We tend to use American Cancer Society's recommendations, which is if you're in a high-risk group, African American or family history of prostate cancer, that you have a discussion with your healthcare provider about the pros and cons beginning at age 45. Other groups, American Urologic Association, recommends that people consider getting their first PSA at the age of 40 and then using that as a baseline to compare it against your subsequent PSAs for change.
I totally agree, other than this is an emergency situation, in my opinion, because only 1 out of 5 men are routinely screening for prostate cancer using a simple blood test called the PSA, as we've talked about. And this simple blood test, the PSA, can be done at the same time that you go for a cholesterol or a blood glucose level, a normal visit. But many primary care physicians are not spending the time to have a discussion with their patients regarding the importance of getting this simple blood test. The prostate-specific antigen, the results do not tell you if you have prostate cancer, but it does give you a snapshot for the health of the prostate gland so you can know what is my next step. Should I have additional blood work done to determine if this elevated PSA is due to prostate cancer or is it due to maybe a benign condition like an enlarged prostate gland, which is much more common in men, having an enlargement of a prostate gland leading to an elevated PSA than actual PSA indicating that there is a prostate cancer.
So are men, especially black men, reluctant to have these kinds of conversations with their physicians about prostate cancer? I'll ask Dr. Bullock first and then Dr. Hall.
No, I don't think so. I think that African American men are concerned about health care and want to have the full discussion of what's in the best interest as any other person who takes the time to actually go see their health care provider. The problem is probably not with the men. The problem is with the system where men are not being given that discussion about PSA screening and the being informed of this well-described disparity with prostate cancer. Prostate cancer is the most common cancer that a man can get. A U.S. man can get it. It accounts for 1/3 of all newly diagnosed cancers. It would be the same as a woman 50 years old never having her healthcare provider bring up the subject of a mammogram. People would say, well, that's wrong. You're seeing your doctor, and your doctor never mentions a mammogram to you. I think it's the same as with a PSA. Well, if it's the most common cancer you could get, why aren't health providers talking about it? So therefore, the onus is on us. We have to bring up the subject and ask for it.
And I would agree with Dr. Bullock that not only is it the most common cancer, but it is the second leading cause of cancer death. Now, you might say, how can that be? This is so common. It's a simple blood test. It's actually easier to do than a mammogram or a colonoscopy. And it's because the PSA stands for prostate-specific antigen, and it is specific to the gland but not specific to cancer. So when you do this first test, the value may be elevated. And let's say we use the classical number of over 4. And that value may be elevated, but that doesn't have to mean at all that you have a prostate cancer. You just might have an enlarged prostate gland or a bit of inflammation of the prostate gland. There are now so many new and very good tests that can determine whether you should have a biopsy or not. And one of the concerns in the healthcare arena was unnecessary biopsies. But we now know that we don't have to go straight to a biopsy with an elevated PSA. And so just educating primary care doctors that there are other simple tests to do to distinguish a PSA that should go to a biopsy versus an elevated PSA where you don't have to do a biopsy, but it's clear it may be due to a benign condition.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Janine Cook-Garard, along with Nassau Community College student Gina Peter. And today we're learning about prostate cancer and how studies show that it affects Black men more than men of other races. Our guests are surgeon and urologist, Dr. Arnold Bullock, and radiation oncologist, Dr. Lannis Hall. So talk to me more about that PSA that should go for a biopsy versus one that just suggests an enlarged prostate. Tell me the numbers there and the categories that would suggest cancer versus an enlarged prostate.
There are several tests, a PCA3, a prostate health index, 4K score. All of these are very good tests that can be done to determine what should happen next, including imaging with an MRI. And then I'm going to let Dr. Bullock, because this is where he is excellent at really describing this, where you would go next after you've had an elevated PSA and you've done these tests and you decide that you should have a biopsy.
So if you decide you would have a biopsy, and some of it is partly dictated by insurance, especially for a first biopsy, that we still do a lot of office biopsies. An office biopsy truly takes 4 minutes to do. Man walks into the office on his own by himself. I'd say it hurts about as bad as people getting their blood drawn twice. There's a little probe that goes in the rectum and takes ultrasound images of your prostate. But many men, especially if they've had an MRI, then the biopsies are done under anesthesia, under sedation, where you can target a specific lesion seen on the MRI, and that does increase the accuracy of a biopsy.
So, Dr. Bullock, talk to me about treatment. If someone, African-American male, is coming into your office and they have been diagnosed with prostate cancer, what is the treatment options?
So one of the positive things about prostate cancer is very, that this, one thing we want to dispel is this myth that, don't worry about it, it's prostate cancer. Men don't die of prostate cancer, but of course they do it at about the same rate as women succumb to breast cancer. But there are, at least 25% of people who have prostate cancer where the cancer is very low in volume, only a little bit of it, and very low aggressiveness. And those men could reasonably be watched on a program called active surveillance, where we follow them very closely to ensure that this cancer really is staying stable. But on the other hand, there's some men who come in with very aggressive prostate cancers, and if it's found to be localized, hasn't spread, then we would recommend definitive treatment, most commonly with either removal or radiation therapy. And then you have some older men or men who have advanced disease where we give them medicine to lower the hormone to just medically control their prostate cancer. There's a lot of options, and that's why it's important that you meet with your initial consult and strongly consider a second opinion, just to get different opinions. Just like you do when you wreck a good car. You don't go to the first shop and let them fix it. You get multiple opinions.
Dr. Hall, what advice do you provide to your patients and their loved ones to help navigate the treatment process after a diagnosis? And same question to you, Dr. Bullock, when she's done.
I start off with what every man should know. And every man should know what their PSA is. They should know their Gleason grade, meaning how aggressive is the prostate cancer. And they should know if the prostate cancer is confined to the gland or if there's evidence of spread to immediate organs or distantly. Those three factors then funnel into a risk group. Are you low risk, intermediate, or high risk, or locally advanced? and men need to know what risk group they're in. Many men, if they are screening, will be diagnosed with low-risk prostate cancer, meaning a small volume and a slow-growing disease. So those men, the guidelines are that they don't immediately undergo treatment because that prostate cancer may never progress to be what we call clinically significant, meaning that it will threaten or cause symptoms or impact their overall lifespan. But as Dr. Bullock said earlier, some men are diagnosed with highly aggressive prostate cancer where we have a window of opportunity of cure. And so advocating for knowing your numbers, knowing what risk group you're in, and then knowing your options, what is guideline directed, is so important because we have data that shows that African American men more commonly don't get the proper care for the proper risk group. And we are out here advocating for men to ask for a PSA. And then if they are diagnosed with prostate cancer, to make sure that they're having a multidisciplinary discussion with a surgeon and a radiation oncologist and possibly a medical oncologist.
So doctors, give us some of the early warning signs for prostate cancer. We'll start with Dr. Bullock.
So that is a very important thing. You know, there are a lot of men tend to be more optimistic than women, they say, in terms of medical care and the status of where we are. And that is potentially very harmful because I've had people say, well, doc, you know, I don't feel like I have prostate cancer. Wouldn't I feel if I had prostate cancer? The answer would be no, you probably would not. While the cancer is still localized to your prostate and at a very curable stage. So everyone's cancer starts off small at some point. And when something is very small, it's unlikely that it would be symptomatic. And so people, men will not have troubles passing their urine, won't have blood in the urine. They won't be losing weight or have pain in your bones until the cancer begins to grow and start to spread. And that's the purpose of preventive care, that you go and you get a PSA to know your risk of prostate cancer before you have known cancer. You go and check your cholesterol before you have a heart attack. You go and you get a mammogram before you can feel a nodule in your breast. And PSA is no different, that it's essential for preventive care to work. That means you're getting a test when you have no reason to get the test except you're in a category of risk. So, African American, you're in a category of risk if you're over 45. That is the basis for the PSA. Once you're symptomatic, it is no longer a screening test. It's a part of your diagnostic testing. We want men to use it as a screening test.
So, Dr. Lannis, if I was a male and my brother had prostate cancer and my father had prostate cancer, is it more, do I have a higher propensity for having prostate cancer?
Yeah, so what are the risks? And we separate risks into what's called modifiable and non-modifiable. Modifiable are risks that you can change, and we always like that by saying, oh, if you eat 5 to 9 fruits and vegetables daily or exercise daily, you're going to lower your risk of developing colon cancer. Well, we would love to be able to say that easily with prostate cancer, and we really can't. That doesn't mean you shouldn't do those things, because let's remember what is the number one cause of death in men and women is cardiovascular disease, and what I just said, exercise and diet matters. But we have a lot of what we call non-modifiable risk factors for prostate cancer, meaning if you have a family history, those first-degree relatives you just named, that's a father, a son, or a brother, you increase your risk a little bit over double by having a first-degree relative with prostate cancer. And if you have more than one, that risk even goes up more. So a family history increases your risk of prostate cancer. If you have someone in your family that has a history of breast and ovarian cancer, and they have a mutation that has been documented, like a BRCA mutation that increases the risk for breast and ovarian cancer, it also increases the risk for prostate cancer. So you should be also screened at an earlier age. So having that mutation, that change in the gene. So there's a hereditary profile, a genetic mutation that also increases the risk. And finally, this is a disease of older men. The median age of diagnosis is 69. So as you get older, your risk of prostate cancer goes up. So your age, your racial group, African American men having a 70% higher incidence rate, and your family history is all very important in this disease. And these are things you can't change, which is why the PSA, that screening test, really levels the playing field. And performing that screening test earlier in men with a higher risk is quite important.
Dr. Hall and Dr. Bullock, I really admire the advocacy that you're doing on prostate cancer. Dr. Janine Cook-Garard is a professor at Nassau. I'm a student there, hoping to work in healthcare. How do people in healthcare, family members of obviously anyone who knows a male, we want to spread the awareness for the men in our lives to get PSA testing. How can we get in touch with you and get more information? Do you both have a website or any resources that we can look for?
Well, we actually do have a website. It's called Prostate Cancer Coalition, STL.org. And our contact information is on there, along with some podcasts that we've done and general information on prostate cancer and what we're doing here in St. Louis. But we also recommend that people consider another website, knowyourprostateplan.com, or go to the American Cancer Society.
Thank you for being here, doctors. And we thank you for a very relevant, a very timely, and a very passionate session with you. Dr. Surgeon and Urologist Dr. Arnold Bullock and Radiation Oncologist Dr. Lannis Hall. We hope you stay safe and continue to do the great, awesome work that you are doing. And thank you for being our guest today.
Well, we appreciate the opportunity to be on WHPC Radio. This is really life-saving for some of the men in your audience, and we appreciate the opportunity.
Thank you, Gina, and thank you, Janine. We appreciate your time.
This is Dr. Janine Cook-Garard from the nursing department here at Nassau Community College, along with nursing student Gina Peter, and we want to thank you for listening to this week's edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.